So we're going to talk for a little bit more than 20 minutes about the rationale for the guidance of biopsies. Since the original protocol published in 1984, which suggested that the six-core protocol could become the standard of biopsy, few people realized that this protocol was proposed in a clinical setting of a high prevalence of the disease, 69%, and in a setting of a clinical prevalence much lower, than 30%, this protocol it appeared very soon that this protocol was not accurate, and the detection rate with this six-core protocol is less than 30%. Now, and very rapidly, it's been recommended to use a 12-core protocol because including biopsies of the lateral region of the peripheral zone, and this led to a significant increase of detection rate. The current detection rate of a standard 12-core protocol ranges between 30 and 45%. But let's have a look at the influence of the prostate volume and the number of cores which affect the detection rate. From this graph, it's obvious that the size affects a lot the detection rate. The smaller the prostate, the higher the detection rate, which can be expected. And with regard to the number of biopsies, if you discard the six protocol biopsies, well, there's not really a spectacular difference between 8, 10, 12, or more than 12 biopsies. Finally, it's been acknowledged that for prostate of less than 30 cc's, the red protocol is enough. 8 biopsies would be sufficient. For prostate between 30 and 50 cc, the green and the blue protocol, that is 10 or 12 biopsies, would be accurate. And nobody really knows if above 50 cc, the increment of 2 additional biopsies per increment of 10 ml of prostate does really increase significantly the detection rate. Whatever the number of biopsies, the consequences of this increase in cancer detection rate, of course, led to a migration of the demico risk to the low-risk group, because 80% of detected tumors are non-palpable, the so-called T1C stage. And you can see on the graph, the low-risk group increased from 30% to nearly 50% over the past 10 years. This is the first consequence. The second consequence is that even a standard 12 biopsy protocol have adverse effect. It does have adverse effect, as reported in 2010, with a special concern about infectious complication. With here, as shown in the blue curve and the green curve, especially patients without cancer, and also patients in whom biopsies are repeated. So the other adverse effect, of course, has been shown by the previous speakers. Even if it decreased the mortality by 20 to 30%, maybe. The study by Schroeder and colleagues showed that to save one man here, you have to detect 1,400 of them, and you have to treat an additional 48 patients unnecessarily. So clearly, a 12 biopsy protocol overdetect and overtreat non-significant tumors, and that has been clearly showed by Professor Schroeder. But not only it overdetect, but it still underdetect. It underestimates also the high-risk tumors. And even in the range of lowest PSA values, it's been reported that up to 20% of cases on the radical prostatectomy specimens harbored a PT3 stage and or a Gleason score 8. And one positive biopsy out of 10 can correspond to a PT3 stage and or a Gleason score 8 in 10% of cases. So this finally refrain physicians to offer either active surveillance or focal treatment because of the fear, legitimate fear, to underestimate the tumor risk. And finally, many patients ask for radical treatment of insignificant tumors. So, how to decrease the underestimation rate of tumor risk? The first solution is saturation biopsies. They can be done transrectally, up to 40 cores. They can be done transperineally, up to 90 to 100 cores. And this, of course, has improved. These protocols improve the value of a 12-course protocol. It can be used to re-evaluate a microfocus on a standard protocol. It's been shown that on a protocol including a microfocus on 1 out of 10 cores could be upgraded to a significant tumors in nearly 70% of the cases, but at the expense of a 32-core repeat set biopsy. And if you use a template biopsy, that is between 60 and 90 cores, you can definitely confirm that the microfocus does correspond to non-significant tumors in approximately 90% of cases. But again, this strategy has limitations because it requires for the template biopsy general anesthesia, which is always questionable for a diagnostic test. It includes complication, the same, but they increase the complication rate, sepsis, bladder retention, hemorrhage, and according to some authors, it still undersaturates large volume prostates. So where is the true alternative? You may guess that the answer is this one. We have to image the prostate like any other organ of the body to target the biopsies, either with TRUS-MRI image fusion, either with inboard MRI-guided. The expected result of this strategy would be to detect only significant tumors, would be to decrease the over-detection rate, and also would permit for a more accurate selection of treatment options. There are 3 modes of TRUS-MRI image fusion. The first, used by a lot of urologists and clinicians doing biopsies, is cognitive, by a visual overlay of what you see on MR during the biopsy. And the 2 other techniques are software assisted. It's non-deformable, that is rigid, without taking into account the shape of the prostate. And the third one is the deformable, that is elastic registration, which take into account the shape of the prostate, which is different on MR and on TRUS. This is an example. This is an anterior target, perfectly visible on MR, but the day of the biopsy, TRUS cannot detect, as it often happens. So the physician who performed the biopsy needs a document, a printed document, or a workstation to visually, mentally, cognitively decide that he should stick the needle in this anterior portion of the prostate. Intuitively, the accuracy of this technique may decrease with the depth of the lesion, that is anterior tumors and or large volume prostates. The second technique is the rigid deformation, non-deformable. It relies on, it uses a navigation system which localizes the probe. The probe, it's a global positioning system which exclusively looks at the probe, not at the organ. And this is the transmitter placed close to the patient. This is the receiver placed on the probe. And you load, this is the target here, which you can see it on this ADC T2B2000 and injection here on the right side. Now, then you load the image on the TRUS equipment, you overlay with internal points or with the contour, and once you're satisfied with the overlay, you just activate the GPS. And so when you move the probe, it is spectacular. And this is why the reason why these systems are so popular, because they're attractive. Because when you move the probe, you move the volume of MR while you do the biopsy. But look, when you push, the prostate is moving forward. When you swap the prostate with the TRUS probe, it moves also. The patient moves. All these limitations have the main consequence that it leads to an error in the registration. So you have to undo it and redo it all the time. I've been using this system for nearly 2 years. It can work in selected cases like this one or this one. Anterior lesion here, perfectly visible on MR, not really visible on TRUS unless retrospectively with a retroscope. It's a very nice tool we use sometimes. And then again, this is you biopsy with confidence the lesion because the target is virtual because it's seen on NMR, but the biopsy is really TRUS-guided. The third technique is a deformable. Deformable, this is the planning phase with the target anterior located here. It's dark, bright, and vascular. First thing to do is to contour the prostate. So you load a 3D volume within the workstation, and you adjust a statistically based mesh made of thousands of points, which you apply on the prostate, and then you just deform it by a couple of points to fit it to the contour of the prostate. You do the same thing with TRUS. You need a motorized true 3D probe to do that, and you adjust with the same technique the contour to the contour of the mesh to the contour of the prostate, and then you place, of course, a region of interest on T2 or diffusion, and then you activate the algorithm which performs a geometric registration with deformation of the shape of the prostate on MR so that it can adjust accurately to the contour of the prostate on TRUS. The targeting error has been tested in the phantom. It's between 1 and 2 millimeter. Now, you're not finished. You have to do the biopsy. So you acquired your volume, and the acquired volume has to be registered to the reference volume. To do that, you need again to registrate, because initially this is the acquired volume on the right side. This is the reference volume, and see, the registration is poor. But after 2 rigid steps, you adjust the anterior portion like this, and then you continue with a third step with a voxel-based or iconic, and you're going to see that the talent of physicians can lead to this. It's going to be totally adjusted. So now the acquired volume before each biopsy is registered to the reference volume. And because the reference volume is also registered to the MR volume, you're ready to do the biopsy. But how to do it? The accuracy first of the TRUS, yes, the accuracy of the TRUS mono-modal registration has been evaluated its accuracy is less than 1 millimeter. No, now you have your acquired volume during the biopsy. You aim during the biopsy. You aim this area, and if you're good, you on the reference volume, the needle tract is there within the target, which can be displayed either on TRUS, on MR, and this is in 3 biopsies are enough to diagnose these anterior high-grade lesions. In some cases, the conspicuity of the lesion is not that high, at least on TRUS. You see it on MR, but you better see it on diffusion than on T2. So you aim at the presumed area and you do a virtual biopsy. So you don't activate the biopsy gun, you just have a virtual tract. You make a first try, you do a second try, so you have still to adjust, and when you're adjusted, you can do 3 biopsy within the center of the tumor. You can use either T2, you can use either diffusion, which may, but we didn't validate that yet, which may be useful to target the darkest portion of the tumor to try to pick up the high-grade tumor contingent of the tumor. And this also works for small-sized tumor. Here, a small anterior tumor visible in the lateral horn of the peripheral zone, well displayed on B2 standard image, and the final result after the double registration steps leads to pick up a cancer length of 2, 6, and 4 millimeters on the 3 positive cores. The results, many studies report, all of them report that targeted versus sextant increased the cancer detection rate up to, and it can reach, the cancer detection rate can reach up to 80 to 85% for PI-RADS score 4 or 5, which are easy to diagnose. It also increased the high-grade cancer detection rate by approximately 40%, and least but not the last, it decreases the detection rate of insignificant tumors. Now, if you want to compare cognitive versus software-assisted registration technique, one study concluded that the cognitive significantly performed less well than rigid registration, but this was concerned 2 consecutive series. The patient was not its own reference, and so it may be less valid than 2 prospective studies recently published, which concluded that cognitive and rigid registration techniques performed equally. So the brain works as well as the software. But more recent studies reported by Daniel Portales here in this meeting may suggest that the cognitive registration is definitely less accurate than the elastic registration. It is a prospective study. MR reading is done in consensus by the radiologist and the urologist. This test was intended to test urologists, the performance of a urologist, used to sextant biopsies, and the protocol included a registration of all biopsies, even those without the target, that is 2 cognitive biopsies without displaying the target, and then 2 other biopsies with the elastic registration system. And then the study wanted to compare the performance of these 2 sets of biopsies. And there was a highly significant difference with regard to the main distance to the center of the target, 10 versus 4 millimeter, with distance to the envelope of the target, 6 millimeter versus 1.3 millimeter, and also with regard to the cancer detection rate, which was higher with the Coalesce-guided biopsies. This is to tell you that if you're not convinced by the fact that you should target with TRUS, a TRUS technique, you may have the option also, because it is done in quite a few centers, but it is done to do the MR guidance, the patient in the bore. That is, provided you have a compatible material, an intrarectal device, a needle, and also, at least at the moment, a 3T platform to have the best quality as good as possible during biopsy. Maybe it will be as easy to do them with a new 1.5 Tesla equipment. They are more or less time-consuming. In a recent review published in ROFO, between 19 and 2 hours. But of course, with a mean duration time of 50 minutes. So it's quite a long examination, but of course it depends also on the number of cores you take. The mean was 4 in the review. The accuracy of the technique has not been done. It has not been compared yet with the TRUS-MR with that of the TRUS-MR fusion. And the detection of tumor aggressiveness also as something which has been further evaluated because some papers from the group of Nijmegen said, like we do with TRUS fusion, image fusion, that the biopsy could be guided by the ADC map, which is conceptually a good thing. But during, I think, as far as I understand the technique, during the MR-guided biopsy, you don't have you can't use the diffusion image to guide the needle. So it's time for my conclusion. I think that all these techniques really rely, as said by Hedy, on the selection of true suspicion areas. That is, it's crucial to establish a score. And I think that score 4 or 5 is easy to establish. But the problem is that if you want really to select it to improve the patient's tumor detection, we have to be really to work on the definition of what is a score 3. Score 3 means I cannot eliminate a significant cancer. I think that some score 3 should be followed up, So 3F, some score 3 should be biopsied, but all this is totally depends on the establishment of a scoring system in a structured report. The rationale for an elastic fusion system is, for me, is the fact that it's a true prostate tracking system. It's the only technique which tracks the prostate, not the probe, the prostate. So the prostate can move, it still tracks the prostate between each biopsy. So the motion also of the patient is no important. The motion of the prostate is no importance because between each biopsy the organ is straight. It is a fundamental difference, and this may be which makes the difference. If this technique is once used for focal therapy, would the transrectal approach be accepted and validated? But of course, MR guidance at the moment might be only a second-line guidance. That is, after a suspicion of false negative TRUS-MR fusion result. Maybe a score 4 or 5, which does, but it's not a tumor on TRUS-guided with fusion biopsy should go to MR guidance. And it's expensive, although attractive, but it's definitely promising for focal therapy. Thank you very much.